And now we're live. Back at it again. It's been quite a hiatus, Larry.
I know. It was nice while it lasted, but now we're back.
Been a while, yeah. So we actually moved out of our other studio, as you guys could tell. Brand new set, all new design, and we're back at it. We're going to hit the ground running. And speaking of hitting the ground running, today we've got Mike Fishweicher.
Got it.
I knew I would. It's a very interesting last name, Fishweicher. Does that mean anything? Or
It's a great question. And the best part of the name is that as hard as it is, nobody ever forgets it. So
Definitely
I can meet someone at a trade show and not run into them until 4 years later. And they're like, yes, I remember you. But it means fish cleaner in Polish. That's what I've been told.
Okay.
Because my father's maternal family is from Poland.
Okay.
But beyond that, I have no clue.
Interesting.
I know nothing about fish cleaning. I eat fish sometimes, but sometimes I go fishing, but that's it.
Okay. But what you do know is consulting.
Yes.
And that's kind of what we're going to be talking about today. You're in the medical / software consulting. Help me get this right. I know, Larry, you guys know each other a little bit more than I do. Tell me a little bit about yourself.
So my focus is in the healthcare technology space, specifically with software that focuses on medical care and aggregating and making useful data out of patient clinical data. That's what I focus on.
Okay. And have you seen a large change or shift in technology? I mean, how long have you been doing this?
So I started about 19 years ago.
Okay.
I would actually work full-time and go to college twice a week at night. I went to a specific night program that was meant for people that work full-time so that I can get my bachelor's degree while working at Microwise Technology.
If only something like that existed nowadays where people can go to school at night.
I mean, yeah, there is kind of like
Night
it's
school?
besides
I feel like it's not as common as it was before.
it's okay. I mean,
I think the internet has a lot to do with it because now you can take online classes and that's
whenever
starting
you
to be
want.
more legitimate than it used to be.
Yeah.
You know.
I mean, I obviously know you from the early days of Microwise, and I wanted to get kind of an understanding of the history of the industry from at that point. What was going on? What was Microwise's agenda at that point from what you were doing in terms of your role and that involvement, and then kind of converting over to now in the present day. So what kind of shift over time? But at that point in your career, what was going on with the industry?
So that's a great question. First off, I want to just preface by saying I've always been tech savvy, but I'm not a software engineer. You know, I was, in fact, it started when I was in elementary school. I had such bad handwriting, the teacher said to my parents, you should get him a laptop to take notes, which was unprecedented at the time. Nobody ever thought of doing something like that, but they did. They got me, I think it was forget what brand, maybe Acer or something. The point is I took it apart, put it back together, learned everything about Windows 3.1, and that's really where my love for software and computers began. Fast forward, many years, and by chance I met with the president and founder of Microwise Technology when he was doing a demonstration for somebody I was advising for their physical therapy practice, and I really didn't know much at all about medical software at the time. When I heard the word software, much like many other people, my mind would immediately think about Best Buy or off-the-shelf software that you would go to the store and buy. I mean, this is still in the days where you had to buy a copy of Microsoft Office, not download it, keep in mind. So to me, software was something that was inherently off the shelf all the time. I didn't understand at the time, before I met this gentleman from Microwise, that there was actually a market for software that wasn't off the shelf, that was very expensive. So that's where my first very basic understandings of healthcare software came into play.
For somebody who's completely out of the game of software, can you explain what Microwise is?
Yes. What do you want to take that? Because
I mean, you can take it right
I
ahead.
have no
It's all
clue.
you. You spend more times working there than I have. So it's all you.
okay, so MicroWise Technology it was a New York, New Jersey based value-added reseller for McKesson, which whether or not you've heard of them, you know them because they are currently, I think, number 11 or 12 on the Fortune 100 list. Not in healthcare in America. So they generate a lot of revenue. Anyways, they have software offerings for small to mid-size physician practices that handle everything from billing to also now electronic medical records and so on. So from the very first moment that I saw because there was no iPads, might I mind you, then at the time, when I saw a tablet PC with a human body on it that you can tap and it spits out all these words. This 38-year-old female presents today with blah, 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 and complains of the pain, blah. My reaction was, why is every doctor in the U.S. not using this today? And this is in the year 2002. I couldn't understand at that point how, as the most technologically advanced country in the world, our healthcare system, which is really the most important system as far as I saw it, wasn't, at the top of this tech game. It was shocking to me how many doctors didn't have anything like this. They still use traditional paper and pen for seeing patients. And that's where my curiosity came in. And very quickly, I said to myself, I want to get involved in this and do this for a living because I feel like it's a win-win. I'm helping patients get better care. I'm helping doctors have a better quality of life. I'm helping their staff go home happy and not be overworked. I mean, everybody's happy, Obviously, you can also support a family doing it.
Yeah.
If you're good at it. And I found out over the years I was good at it. And it's not because I'm some sort of magic super salesman. It's because I believed in the product I was selling. And that's key, and paramount, by the way, to anybody out there who sells. If you don't really truly believe firmly in what you sell, it's not going to come naturally, and you're probably going to find a lot more challenges along the way than if you really do believe in what you're selling.
And it wasn't just like a traditional product, right, that you were selling. You were completely changing the lifestyle of doctors from the way they handled patients coming in and out of the practice, like from the way they were being dealt in terms of entering information and everything like that. It was a complete shift in the industry for them. So it was an amazing product, but also in the sense of like you were in the middle of like a whole changing of industry for them.
Right. And just to expound on that a little, because up until that point, like most patients, I really didn't understand much about the concept of why doctors are taking notes in the room. I figured it's so they don't forget who you are. People don't realize that they get reimbursed by insurance companies based on how complex those notes are. In order for them, if they even see you for 45 minutes and they only write 2 sentences, they are not allowed to bill for a 45-minute visit. I mean, they have to have specific levels of, documentation to attest to that visit. And if they get caught even on one instance of overbilling and not having supporting documentation, minimum $10,000 fine just for that one patient, one instance.
Oh, wow.
Yeah.
And so how has that changed basically? So like, is that still the case, or like how is that transition to something else over time, or like, so they were being paid off documentation from the insurance companies. And then now later on, how did that shift?
So when you think about the mechanics of how this works, and forgive me for being transparent, but I'm going to just be straight with you.
That's how we like it.
It's a back and forth tug of war between doctors and insurance companies because naturally these insurance companies are a business and they want to, I don't want to say make it difficult to pay the doctors, but they want to challenge, the doctors to make sure that they're doing the work to, deserve the payout. So, and that's really what the economic backbone of healthcare was built on. When you look at it from a bird's eye view, there's a lot of problems with that. Mm-hmm. Right. Number one, you have the obvious problem of doctors sitting there every night until 7, 8, 9 at night, having to write the whole day's worth of notes out, to satisfy the way the insurance claim auditors would want to see them so they can bill what they deserve to bill. That's the obvious problem, okay? Number two, there's, fundamentally, there's no advancement of care, that we as humans can benefit from those doctors documenting the way because those documents are just going into a folder, into a storage facility in their basement. And yeah, if the insurance company asks for them, they'll fax them because, by the way, they're not allowed to email them. But faxing is allowed. It's a whole nother discussion.
Is that because of security and privacy and
go figure, right? I mean,
is that part of HIPAA?
Yeah, and that's another topic we should talk about in a few minutes.
Yeah, we'll definitely.
But anyways, yeah, believe it or not, HIPAA allows for faxing, but not for emailing unless the email is 256-bit encrypted and so on. So the point I'm trying to make to you is I'm sitting here looking at this saying to myself, and remember, I come from this background where I appreciate the value of data. I understand what you can do with data that's accumulated over time. And it makes no sense to me that we as humans are going to continue to evolve and benefit from healthcare, discoveries the way that we should be if we don't have that data in a shareable fashion. Not I'm saying publicly, but I'm saying so that the greater medical community as a whole can run experiments with that data, can do things with it. It's not being discreetly kept in a database properly. Now, one thing to mention, when I say the word discrete, I don't mean what you may think is discrete. The term discrete in data terms means that, like, if you have a list of allergies, even though in the note it may list out these are the patient's allergies, if the data is kept discretely, it means that there's a database that keeps the allergies in a table where they're listed so that they can be reported on. You can run queries and say, show me all patients between this age and this age that admit an allergy to this with a reaction to this, but not this. You understand? And that's where we need to be, as a population that continues to challenge, healthcare and try and fight so that we can live to older and older ages and find cures for sicknesses. The only way we can logically do that is by appreciating and collecting that data. So I'll leave it at that.
And so I kind of wanted to touch upon something that you mentioned already, which is the idea that obviously insurance, they want to create, for lack of a better way of phrasing this, as many hurdles as possible or a challenge, like you said, for the doctors in order for the doctors to get reimbursed. Do you think that's essentially a disservice because a lot of doctors end up not accepting certain insurances because of how challenging it becomes, and then that affects the potential patients who are looking for doctors who are in their insurance network,
or even going private, not even accepting insurance at all, right?
They're all valid, arguments that many may use to argue that we need a single payer system in this country. I'm not saying that that's what I believe, but I'm just saying that when you if you look at countries that have single payer systems, you obviously don't have these problems.
Yeah. Okay.
But there's also flip sides to that too.
Which is what?
Well, a case in point with COVID. My wife is actually Canadian. She comes from Toronto.
Okay.
Her parents, are, I believe, either in their late 60s or early 70s. Now, it's a standard in Toronto that they have to wait 4 months between the first and second vaccination, which is...
Why is that?
Because they don't have enough to go around. Okay. And, if you break down the reasons why, when you get down to it, it's obviously cost. But long story short, I know people north of the border that have found themselves in situations where they needed care, and the only appointments they can get, for like biopsy in some situations were 8 months down the road. And the way it works, from what I've been told by my wife, is that they have these clinics that'll do it for cash, without going through the government insurance. So if you have the money, you can pay and get, healthcare quicker. So I said to my wife, isn't that basically what we do here? What's the purpose of having a single payer system and socialized medicine if, you're gonna, you know what I mean? You're
Yeah.
defeating the whole purpose. So, but after living here, my wife completely understands the value of why we built our system from the coverage perspective the way we did.
So and there goes like the benefits from that, and to Mina's point, now we have to deal with, like, now we're going to basically talk about that relationship between the insurance companies and
Right.
the doctors throughout
Right.
this, right? You mentioned HIPAA. For those who don't know what HIPAA is, can you briefly just explain basically its function, and then we can talk about its relevancy over time in the episode.
Sure. HIPAA is, as many may have heard it before, is basically a privacy act that essentially it entitles the patient to a slew of privacy that protects their medical data. Okay, and I don't mean data just like data. I mean their medical information. So when you talk to a doctor, much like if you talk to a lawyer, whatever you tell them is very confidential. In fact, if they break that confidentiality, that's not only illegal, they can, face questions and lose their license for that. But the point is, HIPAA goes several steps further, and there's a lot of, it evolved over several decades. I don't know. You could probably look up and see. I forget what year it was originally instituted, but it evolved into what has become just not only inefficient but also backwards, protection of information. And let me explain what I mean by that. I said earlier how HIPAA has problems with emailing, but faxing is considered A-OK.
Yeah.
Why is that? Well, HIPAA was made at a time when email wasn't really a prevalent method of communication. It was either basically you put a stamp on it and put it in a mailbox, you pick up the phone and say it through your words, or you can use this amazing breakthrough technology of something called a fax mill, aka a fax, where if you pick up the phone and you ever heard one, it's like, dee, da, da. So of course, who can understand what the heck the machine is saying? I mean, so that's secure, right? I mean, that was the logic behind, obviously, why faxing is secure and why email is problematic. Since email can be, and goes through so many intermediaries physically, like when you send an email, it's at a hosting company. It can be retrieved, by people that aren't physically at the location where, that's why there's all these problems with it. HIPAA even, for example, forces practices, and again, this is just assuming they do right by HIPAA, they're not allowed to have sign-in sheets. You ever been to a doctor's office where they have a sign-in sheet?
Yeah.
That's a violation of HIPAA.
Really?
People wouldn't. And so now what they may do is they'll still have the sign-in sheet, but they put them on labels so that as soon as you sign in, they take your
remove
label
it.
and then put it, But I see that and I say, you guys are missing the point. We need to just throw away paper and pen in medical offices.
Yeah.
We have the technology and the software to totally support the workflow of any, thriving medical practice.
So why don't they? What's the hesitation? What's going on with these doctors' offices from adopting like what's currently available?
Great question. And that was something I would face on a daily basis, challenges or reasons why doctors wouldn't feel like they're ready to take the leap. A lot of it, in many cases, had to do with money. But with President Barack Obama's administration came, several incentives to digitize medical data. For example, the Meaningful Use Act, which they were basically allowing doctors to buy specific EMR systems that were certified meaningful use by the government, meaningful use ready, and in turn they get a bonus for the purchase.
To move away from a paper system. Obama administration basically just said like you need to get off paper system, get on EMR.
Right. We need to they didn't want to necessarily come out and say we're penalizing you for not doing it, but we'll incentivize you for doing it.
Okay.
Yeah. you have to also keep in mind that one thing I learned over the years working with doctors is, first off, they're very smart people, but a lot of them are stuck in their own ways. God bless them.
Yeah.
And I can tell you stories that would amaze you, but
Is it generational, or is it like do you not see these issues anymore? And like, for example, our generations like
I'll
coming
tell you a
into
quick
doctors?
story because I told this to somebody yesterday. I did a demo once for MicroWise for a podiatrist.
Okay.
The first thing I say when I sit down is show me how you do your encounter notes, okay? I swear to you, and I'm not exaggerating, this guy, it looked like he was creating a ransom note, out of a movie. He cuts sentences out and glues them together with a glue stick and forms a note by taking sentences. He's got it's like an art project. And I was thinking to myself, wow, I'm going to blow this guy away because I'm going to show him how just with a few taps, you're going to have this 2-page beautiful note. And I did my demo. I showed it to him. You want to know what his first question was afterwards?
How much is it?
How am I going to get my sentences glued into the computer? He's thinking about how he's going to glue because he was so attached. Do you understand what I'm saying? Like he was so indebted into what he knows of the glue. He couldn't, remove himself for a moment to think, wait a minute, maybe let me just put this aside and think that there is possibly a better way of doing this. It's hard to break that barrier because a lot of people have been doing this for many years. Keep in mind, a lot of these doctors have been practicing for 30, 40 years. And, who am I to come along and say, listen, throw that out the window?
Yeah.
Right? So
it's basically like, who the hell are you? I've been doing this all this time and I've been doing fine, basically.
It's only natural, and you have to obviously be respectful when you show it to them. You have to understand that a lot of doctors, they're very, they don't like people coming in and doing things that in any way can make it even perceive that it's helping or pushing them to make decisions that they don't want to make. Like, I don't want a computer telling me what patients are at risk of something. I know what patients are at risk. You know what I mean?
See. Okay.
And I
don't
know.
Think it's because it's a risk factor because of all the effort that has gone to that point of their career that they like. They're responsible.
Exactly. They don't want to feel like they're being replaced or that there's somebody watching them or looking at them and saying that, hey, maybe you're not as good as you think you are. And that's, of course, not the intention here.
Yeah.
Just to be very clear. But it's just natural that people tend to think that way. For example, when I would do a demo, a lot of staff, if they're in the room, they think to themselves, wait a minute, this software may make my job obsolete. I shouldn't be for this. But I make it clear to them and say to them, this allows your staff to focus on more revenue-generating tasks. Maybe they're doing things now that aren't generating so much revenue for the practice. Wouldn't it be great if you can use those same staff members to do things like market the practice in better ways or in other ways to get more patient flow? And that's the more productive way of looking at it.
And that gives a lot of insight to people who are experiencing like when they're actually going through the doctor's offices and they criticize maybe their experience going through it, and this conversation gives them that insight of like basically what it's blocking them essentially from advancing that experience. And you've already mentioned like there's many hurdles of that. I want to get to, you were talking about how they were getting paid based off the documentation in the early times. Now, you and I and Mina were talking about fee for service, and how is that? So you were saying that they weren't getting charged for how long you were at the doctor's office for. Did we? So then was fee for service the next step from that documentation payment?
So they do get paid based on how long. Basically, there's different codes that procedure codes they're called, but in order to bill a higher procedure code, you better be prepared with documentation to show and satisfy that level of coding. So, you have codes that show either a 15-minute visit, 30, 45, but if you're billing 45, you better make sure you have, the necessary amount of certain amount of review of systems in your encounter note. You need to have, subsets of your chief complaint that describe location, the timing, severity, risk modifying factors, all of these little things that doctors are not robots, so they can't sit there and spit this out, from the top of their head. But what if, hypothetically, work with me here, if I gave you a piece of technology, a piece of software that starts out your encounter note as complete as it can possibly be for every type of abdominal pain patient, let's say that's why they're here. And all you have to do is change what's different about this patient. Logically, I mean, you're working backwards, but it's the smarter way to work because now I have a full note. I did everything on there, and I don't have to sit here typing it afterwards,
But
right?
doesn't that cause or create an issue from the insurance side where they start to see the repetition?
Well, so great question. So, and specifically because these systems would have features like new from old. What that means is when the patient comes for a follow up, you can just simply click on that last note, and it uses that as a starting point for a new one.
Yeah.
So naturally, remember those insurance companies who are playing the tug of war we talked about. Obviously, there's not a whole lot of problems they can have with it because, hey, that's what you wanted to begin with. We're giving you your full documentation. We're giving you everything you asked for. And they are losing the battle on that. And that was really the big return on investment that I would use to show doctors when I would sell the software. This is where you make your money back. I mean, bottom line, the American Academy of Family Physicians back then, I saw a number that they said, and this was published, 96% of doctors at the time were underbilling. Why? Because they didn't want to raise a flag with the insurance company and get audited. They figure, listen, I may be eligible for that 45-minute thing, but I'll bill for the 30-minute because I don't want the headache of having them coming and auditing me. I say to them, what do you mean you don't want the headache? If you're doing the work, you should be getting compensated for it. That's crazy. And if it's just because you're scared that you missed something in your handwriting notes, we're all human. I understand that's a reason to be scared, but use the software or this technology that protects you, essentially. There was one cardiologist that comes to mind. We were going back and forth with this guy and for years. Finally, he called me up one day. He said, I'm embarrassed to tell you this. I got audited yesterday and over $100,000 in penalties.
Wow.
And the next day I was in his office doing the implementation, and those situations, I mean, obviously, I'm happy that ultimately they came to their senses, but insurance companies are realizing that, these EMR systems are very efficient and they have to do things, differently, I guess, from the way they've done over the last, 40, 50 years.
So the doctor, so the clinic fills out these notes. They're trying to get reimbursed by the insurance company. Now, out of curiosity, is a person reviewing these notes from the insurance side, or is this also computerized?
So what happens is the insurance companies are allowed to audit the doctor's notes. They don't review every note, but if they do an audit, then they do review every note. So naturally, they have their own systems in place on their end that probably raise flags based on what situations they need to audit people. But I've heard stories where an auditor comes in and they're using, something from MicroWise that we sold them, and they said, "Oh, forget it, my job is done here." They realize they're not going to win because you can't find fault in, That's really what these auditors look for are instances where they may have been, overbilled and don't have the necessary documentation to support it. That's really, what they look for.
So Larry and I were kind of talking about exactly what we wanted to bring up to you and extrapolate from you. And so we were talking about the, doctors getting reimbursed based on the time that they spend with a patient. Now, apparently, there's this new transitioning process of payment that Larry
Value-based
mentioned.
reimbursement, right?
Value-based, which when he kind of summarized it by saying doctors getting paid based on improvement or change in the patient. Kind of sounds appealing.
Very. All right. And it started actually back when I was still at MicroWise with a little experiment that I believe it was Medicare they ran called PQRI. It stands for Physician Quality Reference Index. And what that was is they would basically say, if you would submit to us, the government, certain metrics of immunization data, and they specified what those metrics were, we would give you bonuses for that. And I saw, and I had the foresight back then to see what they were doing. I understood that they're just basically tiptoeing before they ran with this whole value-based, I call it VBR, value-based reimbursement model.
So you saw the foreshadowing.
This
that.
is exactly and quite frankly, they need to go in this direction. Where what that means is that they are trying to.
Who's they? The insurance companies or the government in this instance? Like, who made this decision of value?
Obviously, I mean, the insurance company, they lobby for what they want. So, but at the end of the day, it's the government that's making, the decisions here. What they want to do is, and I'll explain it to those who are watching or listening and don't know much about this space other than what they see when they go to the doctor. They realize that, like a lot of things that the internet and that data has revolutionized, healthcare too has to be revolutionized, economically, that is. And what I mean by that is they need to start reimbursing doctors for doing a better job rather than spending their time. Because I can walk you into certain clinics that are just like a factory where you wouldn't know the difference if they were cars coming through an assembly line or patients going through it.
Yeah.
And that's not what we want to see either. Listen, it may be efficient for the doctor, but the real underlying problem, I'll tell you as a patient with it, is most people, whether they realize it or not, have a deep inherited trust in their doctors. They somehow believe that if I'm at risk for something, my doctor's going to call me and give me a heads up.
Which is not the case.
Most exactly, of the time. Exactly. I mean, listen, it's always good to go for the yearly checkups because they can see things they may not have known otherwise, but just think of it. Imagine you were that doctor and, you see the patient maybe once every year at the most, right? Am I going to call you and say, hey, don't forget that your great aunt had breast cancer and died before she was 40, so make sure you get a mammogram? No, right? We need to have preventative care systems in place that make use of data, that give those doctors' offices information to work off of so they can have their staff calling the patients that might be pre-exposed to things like breast cancer genetically, right? And that's a whole another topic, but it's called, preventative care or and all of the EMR systems back then and today have ways of accomplishing that, where they basically have these algorithms written in them so that they can show you patients that might need to, be reminded they should be coming in.
And I want to get to that literally after this quick, since I want to close that part of the conversation. You were saying the insurances were lobbying for the value base because you were kind of hinting at it earlier, is that the insurance companies, if documented well from the doctor's end, they were pretty much always getting their money, essentially, if things were done right through the software. So in the sense that those hurdles that the insurance company at that end, they really couldn't really stop that. I mean, if you were doing it right, you were getting your money. Now, value-based adds some complications of getting that money from the insurance companies, which would you make that argument that it was in their benefit to change it? Or
well, I want to first start out by saying, just for the record, I'm not like an opponent of insurance companies, okay? I mean, I don't want people to get a picture that they're simply completely money hungry, greedy people.
That's fair. Okay.
But they are a business.
Yeah.
Don't forget that, and they are not in business just to be waiting for, a claim from your doctor just so they could quickly send them a check.
Yeah.
That's not how their job is to really, I want to say, push resistance on abuse, because obviously there's a lot of abuse and that's a problem. But also, in a way, they are interested in you being healthy, because they don't make money if you're not healthy. They lose money when you're not healthy.
Because a doctor could just be documenting every visit, but show no progression whatsoever to the patient, and then just keep getting money from the insurance company.
Exactly.
And they'll be like, why am I even paying this doctor all this many times?
And when you look at things from the insurance company's perspective, they have that to look at. They also have the idea of, hey, here's a patient that if he or she gets, the right treatment over the years, even if they may have diabetes or other underlying conditions, we won't have to spend as much money caring for them as if, this other way of doing business played out. If we put incentives in place for the doctor to, be more present and to be more reminding of them to do what they need to do to take care of themselves, in the end, they'll save money. And it's the truth. They will, insurance companies. It's almost like a reallocation of money if you look at it, because obviously they're very smart and they're not looking to spend more money. But what they are looking to do is incentivize doctors that keep patients healthy. Why? Because patients come out better, doctors come out better, and obviously they come out better because patients, that are healthy don't need so much insurance,
And so
payouts.
so that now becomes like a data problem to solve because they need the data to prove that the patient is getting better. Now, when did
Precisely.
this come into play, the system of value-based reimbursement? How long?
Precisely. So
That's from Obama's administration, or when did it exactly come in?
it's been slowly coming into play for quite some time. Okay.
Yeah.
So I was with that company we talked about, MicroWise, until about 2008. I know that in my last year, or last 2 years, I think, was when they started with that PQRI initiative we were talking about. From there, it progressed. And I think by 2010, 2011, they really hit the gas on offering incentives to doctors to go digital, like big incentives. And that was actually a dynamic shift in the EMR market. There was hundreds of EMR companies, and there was a major consolidation that occurred. Companies, 8 other companies, they bought them out. Other companies couldn't afford to stay in business because they couldn't keep up with the requirements that this government meaningful use initiative put forward. Long story short, as your father once taught me, the big fish always end up eating the little fish.
Yeah.
And there's this cycle that repeats. And that's what happened then.
And so now we're at the data. Now we're at the data issue. Now, my father's business, when you even when you were there at the time, you primarily worked with private doctors who are not part of private, meaning just like they're not part of the hospital, and they're pretty much just on their own, running their own business. Now, they were making their money from fee for service. Now, value based comes in. Now, what did they need, and what's the struggles? Basically, now we're going to basically extract this whole like value base from impacting them, because it seems like it's more impactful to a private individual than it is towards a hospital who may have more of a means to handle this issue.
Meaning it's more of a challenge.
Yeah,
Yeah,
exactly.
Right. And to be honest with you, I when I left MicroWise and moved to a different aspect in the healthcare IT space, I started focusing on dealing less directly with practices and more directly with software companies, because that's really where a lot of things happened. Number one, software as a service really took off. The cloud concept of having a cloud out there, it didn't exist when I started at MicroWise, but by the time I left, it revolutionized the industry. And I could tell you how different the industry was over those 8 years. I mean, in a whole podcast by itself,
For sure.
When I started there, it was normal to go into a doctor's office and walk out with a proposal with everything from a server down to workstations. You need laptops. You need, client server software installed. By the time I left, everything was cloud-based. Everything was subscription, pay monthly license, and that really rocked the world for a lot of these software companies.
Which comes into importance with like preventative care, because now it's a consolidation of a lot of data, right? So like now, how are these doctors getting this data? Like, what's that problem, and how are they solving that problem of getting the data?
That's exactly where I was headed. I wanted to say that I went to another company after MicroWise that deals specifically with the interoperability of that data, or the plumbing of that data. So, because that's a natural question, is what happens when mission accomplished? We have all these practices digital. How do I get my doctor over here to send my digital data to my cardiologist over there? Wait a minute, they can't. Why?
HIPPA?
No, because they're using 2 different EMR systems.
Oh, that's yeah.
And that was a big problem with the way this whole EMR system concept was introduced into the healthcare space. Was EMR companies were smart and realized we don't want to make it easy for doctors to communicate off of our system. You want to communicate? Buy licenses or buy our software and communicate on our platform.
It's like the Apple ecosystem. It's like they all use that same ecosystem.
And imagine if you had that mentality, but you had like a dozen or even 5 dozen Apples, like companies that were operating at that level. That's what was happening. And that's a problem. especially from the government's perspective, because they're thinking we're throwing all this money at this meaningful use problem. But
The data's still not shared.
right. So what happened is they came out with another round of meaningful use 2 requirements. So even if you pass meaningful use round 1, now a few years later they said, here's meaningful use 2 you have to pass in order for doctors to get the money. One of the requirements was you have to be able to exchange data between systems. Now, some people may have heard the term HL7.
You could briefly just explain, yeah.
HL7 was formed by the ASTM. It's basically a intermediary language, if you will, that was built to facilitate things like lab results digitally. Now, HL7 is not efficient for the transmission of a full patient record. So the industry realized at that time, hey, we need to have something new to be able to do that. And I was actually, believe it or not, on the committee that formed what was called CCD or CCR/CCD, Continuity Care Records, Continuity Care Documents, where it was basically a ramped up version of HL7, where you can really go to any EMR and do a full proper export of all your data so that it can be properly imported into another system.
Gotcha.
Okay, most doctors, believe it or not, don't realize if I want to switch systems, all I need to do is buy the new one, right? And all my data will just be there. They don't realize that there's
The Apple ecosystem, and they can't
An
really
export
import the
Right.
data.
process.
Exactly. Why? Because they're used to things like, oh, I use Peachtree for accounting, and now I switch to QuickBooks. When I install QuickBooks, it just converts everything. So, I mean, hey, it must be that simple, but it's not. And that's where in 2011, I am proud to say I was actually one of the first people. The company I was with at the time was one of the first companies to really hit the market with full-scale EHR data migration services, because there were a lot of doctors that either were using an EMR system that was not meaningful use certified, and they needed to switch systems because they're getting money to switch. But how are they going to get all this data that they put in there for years and years? They need a company to, make sure it's not only taken out, but that it's put in the new system the right way. Think about it for a second. You don't want like 95 PDF files on a patient just so you can dig through them to see, hey, they're allergic to penicillin. You want to know when you open their record, allergic to penicillin, problem, flag.
Yeah.
The only way to do that is to keep that data discrete, as I was saying before.
And that's so now that's converting from a system to system. Now what's going on with because I know there's systems like this around, and I'm just trying to get this extrapolated. If I'm in physical therapy and I want to know what's all the information that when you went to your radiologist, now that communication, what's going on with that?
So the first step of it was to really make the data exchangeable by making that CCR/CCD format. Second, the government, I told you, they added that to the requirements of meaningful use. And, just to put this in perspective, some of the companies out there that were given that meaningful use certification, Series 2, they put that functionality in their system to export all of the patient records as a CCD. And as soon as they got the certification, they took it right out.
Oh, wow.
I mean, that's how shady in some cases. It's unfortunate, but this is what you're dealing with. And that's why if you're familiar with the healthcare IT space, you'll know there's all these different organizations that say that they're pro the proper interoperability and democratization of healthcare data. These are the fancy words they use. But the fundamental problem is that these EMR companies, at the core, they're businesses, and they don't want to lose customers.
Yeah.
And I've seen them. They basically hold doctors hostage.
But why are they losing business if the doctor's already using their EMR, and then they want to be able to, a doctor wants to be aware of information from a patient that was using another doctor? Is it because they weren't also in that doctor's system?
In those situations, you're right. They're not, but it's what happens if that doctor wants to switch systems. I don't want to make it easy for them to switch. Mm-hmm. That's the thinking that has really put a stumbling block in the growth here.
Yeah.
Now, we're at a point in the year 2021 where we've kind of really surpassed and gotten over that hurdle. There's been a lot of advancements in the last few years. Something called FHIR, F-H-I-R, which is basically a new version of HL7 was introduced that can really facilitate the broad the broad sharing of patient clinical data, like, in a health system environment, which is, a pretty large environment. Health systems generally own many hospitals.
Yeah.
So we're at that level. So I want people listening to feel like we're confident and we're not like, we're not in a position where we're stuck. But I'm just explaining a lot of the
Yeah.
hurdles along the way that companies saw with the growth in this field and why it was so
Like
frustrating.
why it took this long, basically.
Why it took this long, and why, if I could go back 20 years and say to myself, why isn't every doctor using this as a standard? It's this mentality that I've been talking about all this time that gets in the way with the ideal utopian way of the right way of handling data. But thankfully, thank God, we've evolved into a situation where patients are in control in the sense that they're able to see whatever doctor they believe they'll get the best care from. Things like telemedicine has evolved, and that's a whole nother topic. But all these things are moving in the right direction. I'll say that.
Now, sorry, go ahead.
No, I was going to. I'm kind of curious. So there's a ton of data, and we're not strangers to data getting into the wrong hands. And so let's say in a hypothetical situation where these systems are integrated and doctors are inputting all this data, and data is being used for research and innovation and advancement of medicine. Now there's obviously, the other side of it, which the conspiracy theorists would start babbling about data being stolen or breached or being used by larger corporations for whatever other reasons. Is this a topic in mind, and is there anything being done to keep that data safe and secure and out of the hands of wrong people? Is there government intervention? Is there any regulation?
It is absolutely a topic that must always be in mind and is paramount as far as I'm concerned, because we can never lose sight of the patient's right to and the clinic's responsibility to privacy for that patient. Patients should feel comfortable disclosing information at their doctor, that they should not have to think twice this will get in the wrong hands. And the way that data traditionally gets used for scientific use is there's a process called de-identification, where they take out specific identifiers, patient's name, social security number, but they do leave things in, like the age. They leave in their income, their socioeconomic situation, where they live, what the general income level is in their community, things like that, because all those things at the end of the day can play into their experiments to see how their care can be improved.
And that's the preventative care
Yes.
that you were talking about, and the algorithms to basically help the doctor understand that, hey, like the statistics of this patient from what they have could lead to this. You should probably do X, Y, Z.
When I was talking about it earlier, I was really thinking on like a baby step level to where we're at today. Where we're at today is we've really hit that forefront and that crossing level of artificial intelligence, which is a great thing. I mean, just the words AI, it sends shivers down my spine, because it's a huge responsibility.
Yeah.
Our generation is at a massive fork in the road in the broad history of humankind. I mean, when you look at our history as we evolved from however you believe we ended up here as people, whether we came from monkeys, whether there was a big bang, whatever it was, a lot of stuff happened for us to get here. But when you look at the last 100 years, a lot of stuff has changed. And when you look at the next 100 years, a lot of stuff is going to change at a much greater pace. So it's important for us to make sure that those pace those pace changes are not held short by these little obstacles we've seen over the last 2 decades, for example, I've been talking to you about. We want to make sure that we can use AI the way it should be used, so that we can fight cancer, we can fight Alzheimer's, we can fight all these diseases that have hurt and killed people and families and so on and so forth. Because it would be unacceptable 50 years from now to say that we have no progress in the field of Alzheimer's, or, you know what I'm saying?
Is AI playing a a role right now in medicine?
It's starting to, but the natural point for AI to be able to do anything is it needs data. You can't really expect results without providing data to it. And AI, like any intelligence, it gets smarter over time. We've seen, and that's, by the way, on a side note, why I do now what I do, which is I'm consulting in the space I love and helping companies that are either new to healthcare or are pivoting from different industries and applying their technology to healthcare.
Yeah.
I help them from the business side to try and get either outsource business development or try and get the right, marketing in place and understanding and relationships in place to be effective and hit the ground running. Because I mean, you can see some of the greatest technology, out there when they hit the healthcare field. It's like they don't know what they're doing. I mean, I don't want to single out any specific companies, but when you go to some of these conferences, you see companies like, like Uber, for example. I'll just say this publicly. I saw Uber at HIMSS 2 years ago, and I was so thrilled to see they're getting into healthcare.
Yeah.
When I went to them and I said, "Why are you guys here?" They said, "We don't know. We're here because Lyft is here. You see, they have a booth." And it's the truth. But that's what happens, and I get it. And so they have to always be, at competing
Neck
at
to
that
neck,
level.
yeah.
Right. And that's great, because honestly, that's how we make progress and move
With
forward.
competition.
Right. And
Yeah.
Uber, to be honest with you, I don't want to, if they're watching, they've done a lot of great things. Like they were experimenting with, setting up rides for patients that can't drive after procedures,
Yeah.
great, very, intuitive stuff. The point I'm trying to make, though, is companies, they tend to jump into spaces like telemedicine or other areas in healthcare, like, especially now that, data is really being used to fuel AI systems. Companies are really trying to find, sweet spots in healthcare, and I help them do that. That's what I do.
Are doctors' offices equipped enough to gather the data to not only, we were talking about value-based reimbursement, to not only get their money from the insurance companies to show that the patient is improving, but to even find the value towards these algorithms to make sure they're aligned with, basically, it's like a cross-check, right? Like, this is the data I was able to extract from the patient. Now I want to cross-check it with the system to see what the system recommends, basically, or like what's the history of this kind of condition.
Yes. So let me answer that by prefacing it to what have they done before this? Think about it. Have you ever gone to a doctor and seen that physician desk reference, that like 50 book series where they supposedly look up anything they're not sure of, or they go, you know what I mean? Imagine being a doctor and really having to do that. And now imagine a world where it just pops up or is a tooltip on the screen that gives you that information without even thinking about what volume it's in. It's game changing, right? And the whole point is it allows good doctors to continue being good doctors by saving time and not, doing things that waste time. So that's the end game for the small doctors, is to try and help their clinical decision making. That's really the main term that floats out there, is to enhance their clinical decision making. We don't want to make decisions for those doctors. Obviously, we respect them as the caregiver, and a computer is never going to replace the doctor's ability to care for the patient. But if it's going to help the doctor see the situation in a much broader sense than they possibly could have, because it's getting data from all over the place, why not?
Yeah. Now, can you comment on, is this relative to, because from my understanding, the private doctors, a lot of them, after this value-based reimbursement came in, a lot of them seem to not get transition well enough, where they went into the hospitals. So why is that? What has been the challenges from them? That goes to the previous question aspect of were they equipped, or what was the break in that essence? Because that seems to expedite a lot of it.
That's a great question. It's really been rough for a lot of private practicing doctors because they find themselves in situations where they're essentially competing with hospitals, quite frankly. That's really what it comes down to. And at the end of the day, hospitals, they know how to churn out from the business angle and make the best use of doctors' time because they're run by very smart people. Insurance companies tend to like that.
Yeah.
They like working with hospitals. They have negotiated rates with them. They know that there's a lot of oversight and things like that, and they can use, things for their advantage. The point I'm trying to make is doctors have found themselves either fighting with these hospitals to try and stay in business, and in some cases, ultimately having to sell their business to to the hospitals.
This is big fish eating little fish. You're competing with a business that has all the equipment that they would need, right? Against a small fish essentially. And now when you're talking about a data, it's a matter of who has more data. The hospital will outcompete you with that. Is that essentially what it is? What's going to?
That's a great observation you're making, because the hospital is very smart, and they realize that if they have the information and they have the data on the patients will be more likely to come to them for the care.
Yeah.
I mean, I heard this whole scenario, predicted in 2003 when I was at a conference in Las Vegas, and a gentleman by the name of Mark Anderson, who actually he and I still work together in many projects. He laid this whole thing out back then, and he was so spot on, where he explained that the future of healthcare is going to be a community, and he drew a picture of a little town. At the center is the hospital, and their job is to make sure that everything flows into the hospital, because if the data goes in, the patients go in, whether it's for emergency room, whether it's for routine. And what does that do for the practice over here? That's the question.
And it sounds like exactly what happened in tech, right? So now that's a good transition, right? It's like Amazon and Google, now they have the prowess, the algorithm, they have the technology when it comes to like artificial intelligence and in terms of data holding. Are they getting a piece of the pie now, and like what's their involvement now?
So, do you want me to, take a step back? Let me explain, by the way,
Sure,
because when I was digressing on some things to discuss, I figured when you brought this up, I'd mention it. I read a book recently on how Amazon got started and Jeff Bezos, and it's a really fascinating story. But he's a very frugal and very careful spender. There's the famous story that he didn't even have a desk. He used an old door as his desk, because he didn't find that
And his car was like
a Honda Civic.
when he was worth billions.
If you have a few moments on YouTube, look it up. You'll see the interview in 2001 with Jeff Bezos. It's fascinating. I mean, the Amazon office then was literally like a hole in the wall in the middle of like the cheapest retail space you could find. The point I'm trying to make is, it came up at a meeting early on in Amazon. They said, we have all these computers, and all this processing power, but we're not necessarily using all that processing power all the time. And Jeff Bezos looked at his right-hand man. He said, I want you to figure out a way we can, maybe lease that unused processing power out to some companies. Maybe we can just get use of it. Why do we just let it sit there, right? That was the birth of AWS right there. And they didn't have a business plan for it. This wasn't meant to make money. This was just to Jeff Bezos's way of plugging up waste.
No waste.
Exactly. And if he would have known back then that this would be the bread and butter of Amazon's future, which it is. I mean, if you think for a second that they really make their money on sending you, pots and pans, listen, they do well. They learn a lot about you. They keep you happy as a loyal customer. But where they make their money is on AWS and their cloud. People don't realize that everything is stored in the cloud. Even up until recently, Apple's iTunes music would be stored in now finally Apple has their own.
Apple Music,
Right, but I'm saying Apple would rely on these well-known cloud infrastructures to store Dropbox even. They don't have their own server farm. They're using AWS. I don't know about up to today. I know as of like a year ago. The point is that he never would have imagined that. But that was definitely just, a major decision that impacted the future of everything. Why? If you were a startup software company 20 years ago, you had to worry about things like getting a server, setting up a network, having a network administrator, making sure there's protection, firewall. Now you can spin up a network in under 90 seconds on AWS. You know what I mean? Like it's that advanced.
Yeah.
So everything in the cloud, you know, especially healthcare wise, is useful. And then to get back to your question, who controls the cloud? Obviously, you have companies like Google, you have companies like Amazon. Are they in a position to benefit? You better believe it. I mean, whether they know it or not, they're going to benefit from it. A big piece came out a year and a half ago that uncovered a active relationship between Google and a very large health system, where apparently, unbeknownst to the patients of that health system, Google was collecting data. And it was supposedly done legally,
Wow.
because one question I get a lot is, well, how is the patient allowed to, I mean, how does the patient sign off on allowing their data to be used for whatever, for these, you know, either AI systems, whatever. When you sign those forms, when you go to a doctor's office, part of, if you read what you're signing, there's a business associate agreement, and in the HIPAA form somewhere, it basically says that you give us the right to share your information with, you know, parties we work with that might contribute to the quality of care that we give you.
Which is a fancy way of saying big tech.
Right, but it's not like we're selling your data or anything like that.
Yeah.
But you know, leave it to Google to figure out a way to sell it, because I'm sure that will happen, right?
Well, it's the criticism that Facebook got, right? Because all these
course.
third parties that Facebook was dealing with, and Facebook's argument was, you have a better experience if we share your data with these third parties. And if that had a fuss, I can't even imagine now what the battles are going to be with healthcare information with these big companies.
People, they, you know, listen, I think a lot of people don't realize how big some of these plays are. It's a chess game, and there's so many moves ahead that these companies have thought of. Like Fitbit was something that came to mind. I would always tell people when they go and buy a $99 Fitbit, you know, and then this company Fitbit goes public, they think, wow, you know, it's a device company. It's not a device company.
Data company.
It's a data company. They know data based on, and because now they're branching out and learning a whole lot more. Apple was smart and jumped on it with Apple Watch.
Apple Watch. But I want to play devil's advocate for a moment.
Mm-hmm.
Who cares? So let's say, hypothetically, I have high blood pressure, right? My data gets out there. How does that get used? Who cares if
some people
big tech knows?
Some people feel that, wait a minute, you know, now this may prevent me from certain job opportunities. This may, you know, haunt me somehow, because somehow there's going to be a database, a risk database. And, you know, if I have some condition or something, I don't want people knowing about it. I don't want them to look down on me. You know, AIDS, for example, is something that's very sensitive to a lot of people, especially, you know, many years ago when there weren't as many treatments for it. Now, thankfully, there's more treatments. But the point is, it's a very, you know, you have to respect the privacy of each and every patient, whether or not they have serious conditions like that. You have to treat them all, you know, very confidentially.
And that's the job of HIPAA at this point, because we were mentioning it, that how its involvement will be over this time, and it seems like it's going to be at its peak of its responsibility with this.
There's already been little chatter that I've heard where they're trying to basically make it a revamped version of HIPAA, because there's a lot of inefficiencies that HIPAA was made, I think, and again, you can correct me if I'm wrong.
1996.
It was 1996?
Yeah.
Was it created then, or I think it was maybe last revised then? I thought it was made in the 80s.
Began.
Okay.
It was developed in 1996.
Okay. All right.
And it was part of the Social Security Act.
Right. So, okay. Thank you. That's right. It was built to really protect privacy over the Social Security Act. It wasn't really built for internet and for thinking about down the road of cloud. They didn't.
Yeah.
If you would have went back in time and said the word cloud, they'd be looking up in the sky and, you know,
Looking at physical clouds.
They you know,
It's like
obviously-
the challenge with the patent agency with software is like they when they did the patent agency, they only understood it to be like a physical things, right? Like, and then now software came into being, like, how does patents work with software? It's a similar dilemma. It's like
It's a very similar dilemma, sure. I mean, I saw an article that somehow, the submarine was patented like 200 years ago. And, there was no submarines then, but some guy with a lot of time on his hands,
Yeah.
and you know what I mean, figured out a design and somehow patented it, but yeah, that's a great example. And that's why Albert Einstein loved working, by the way, in some way in the patent office, even though he hated it. But he was intrigued by, the stuff he saw come through.
Now, Mike, are you aware? So it's very clear that you're very aware of the space of EMR and just the medical field as a whole. But is this just a domestic situation, or is this also, do you have an understanding of what's going on overseas? And I kind of want to understand the comparison. Are other countries, in this EMR field, are they interested in collecting data also? Where is our health system in comparison to other countries?
That's a great question. So, for the most part, I focus on the U.S. My exposure overseas, though, generally is limited to about a week or so every year when I go to this conference called HIMSS, which happens to be next week in Las Vegas, and I'm going.
Have fun.
Thank you.
Should be fun.
Thank you. But anyways, that's where you see a lot of players from international health systems in other countries come, generally because they like to see what's going on in the U.S. because they copy it and they try and get it to be used in their country. Like I know Dubai, for example, there's a huge revival economically in that on that side of the world of modernizing everything, and they put a lot of money into making sure that they have the best of the best. So they have a whole delegation that comes to this conference, to see what's going on. And all these countries come there to see what's going on because they realize that the best talent, for lack of a better term, is usually coming, out of the U.S. Hopefully, it continues that way. But
And so from those who are listening in, they heard a lot of the history. They heard a lot about what's being figured out now when it comes to preventative care. Now, obviously we don't want to ever leave with any pessimism of like the system. Obviously, there's always a positive outlook to how things are changing, how things are going to be better for the future. Is preventative care is how you would tell someone basically like this is coming, this is going to make your all of our lives a lot better health wise. Like, what's that future positive outlook aspect to what people can look forward to?
And also, what's the timeline?
yeah,
Is this something that's in the
Something
very,
that-
very
yeah.
near future? Is this happening now? Is this still just a thought?
So both great questions. So what I would tell you is just to recall back when I said that most people have this inherent trust that their doctor will call them when there's a problem. Once you get over the fact that doesn't happen, you then start to realize you're in control of your own care. Have you ever been in a situation where you know something's wrong, but you're putting it off because you really don't want to face it?
Yeah, you're afraid of the cost, so you're afraid of facing it as many.
You just don't want it to interfere with whatever it is you have going on. Now, is that the best way to handle something? Obviously not, right? So I'm not trying to say that we can't be trusted with our own care. What I'm trying to say is that we need to apply science, the science and AI benefits to helping us care for ourselves. And the only way to really do that is to learn from
historic data.
and us as a collective.
Yeah.
I mean, when you think about where healthcare has come since, I think modern healthcare was formed in 1862. Okay, over the last even from 1862 to the 1962. Okay, when you think of how far modern healthcare grew in those 100 years, okay, it was based on really just the ability of doctors being able to learn how to care for patients and act on that. Not so much on bringing back what they learned and helping the community as a whole. They did do that through medical journals, but that was it. The internet has changed that because what we're seeing now is a situation where everything is being cataloged, organized, you know what I mean, and broken down, whether we know it, whether we don't know it. In most cases, some companies don't even know what they're going to do with it, but they're smart enough to know that they need to be keeping that data because they're going to figure it out.
There's so much value. so much value to it. It's going to be used to a greater whole, and because someone's going to be collecting all of this, right? So there's
Right,
like
whether
a
it's
treasure to
whether
it.
it's a pharmaceutical company that needs to fine tune some of their medications they have in
Personalized
R&D.
medicine is going to be like a future thing for them, right? All this stuff is going to matter.
I mean, personalized medicine's been around for a long time. Most people haven't heard of it because of the cost, issues. It's fascinating that if you take the same pill that I take, scientifically, if they analyze our brains, you'll see that it affects people differently. Why? Because when you break it down, we're all really just a series of chemicals, and those chemicals are different person to person, generally controlled by our genes and our lifestyle. But the point is that, just as you see, like, for example, the space wars, how competitively these countries that are space-going countries are competing to get, leisure flights up to the, the outer hemisphere, whatever.
Yeah.
So it's amazing to think that, Richard Branson or, Bezos, literally they built, or Musk, they built their own space companies. Can you imagine saying that you did that? I mean, it's fascinating when you think about it. But these are the brilliant minds we need to help us move into the future, to help us facilitate all of this data so we can evolve as a people. And there's always going to be challenges along the way, but we need to make sure that we think collectively and understand that all of these things are meant ultimately to help us, and hopefully they're done in ways to prevent those who are trying to harm us, like hacking groups and so on.
Yeah, it's going to be a beautiful story. It's going to be really exciting looking forward.
I'm trying to set this up for a part 2, so I'll come.
No, of course.
Yeah.
No, there's we've mentioned topics where you already mentioned that, like, you can extract them to a whole different episode on their own. There's a lot of we kind of hit the tip of the iceberg.
Seriously, I think there's gonna need to be a part 2.
There's going to be, because I guarantee you in 6 months from now there'll probably be so much that has changed.
And we need to know what's going on at that convention. So see what's changing at the.
When I started my consulting company, telemedicine existed, but nobody really used it or heard of it. Why? Because insurance companies weren't paying for it.
Yeah.
In 2015 or 2016, that all changed when Medicare started paying for telemedicine. And by the way it works is that usually insurance companies follow what Medicare does. So that was the first domino that fell in a great way. I mean, and the argument for it was, just quickly, patients that live in rural areas, they may have the same healthcare coverage you have.
Yeah.
Their argument was, why should I be less able to see a doctor just because of my location? I'm paying the insurance company the same amount. So if there's technology that I can video chat with my doctor, why wouldn't that suffice the insurance company's needs for, and that was really the birth of the telehealth field.
And that opens so much more opportunities, because now you remove the barriers of your geographic area, of like opportunities for you for your care, and so now it's like open the gate for the whole country to get access to it.
Absolutely,
it's an exciting
very
future.
exciting. So exciting that I decided to go to the ATA, the telehealth conference. By the way, back then, the first year there was like 30 vendors. The next year there was 70. The following year there was 300 or 400. I mean, you see the rate of
it's accelerating.
And when I would go to these companies and say, so, like, what do you guys do? And we have this equipment, that equipment. What do you do in telehealth? We're not sure yet. We're looking to see how we can get, and that made me realize that I'm in a sweet spot, because I try to help companies like that say they're the best at, like Zoom, for example. Zoom, obviously they're doing something right?
Yeah.
But they're having a hard time really breaking into the telehealth space,
And so I think this is a great way to conclude. A person who is very hesitant on telemedicine and data aggregation of medical information, what do you tell them?
Look at COVID. Okay, I was bullish on telehealth before COVID, and then COVID hit.
Yeah.
And now all of a sudden, the same people that said to me, nobody will ever use phones to see doctors, they called me up and said, wow, now I see where, just like that, you had companies overnight panicking to figure out how they're going to continue to open up and see their patients. And I know practices that are thriving and they're still closed physically, but their caregivers are all doing telemedicine appointments.
And it's either you're going to be part of the train of that movement of like better care from using technology, or it seems like you're going to be really missing out on a lot of the
Put
benefits.
it this way, the days of taking off a half a day to go to the doctor are going to end up being limited. So if you don't get on the train, you're going to be the guy in the office who's asking for a day off so you can go to a doctor's appointment. Everyone's going to be like, what? You know, I mean, because let's face it, I mean, it's a huge annoyance to have to sit there, wait in a waiting room, you know, this and that. Obviously, if there's and companies have acted, by the way, on this. Did you know that they're huge companies? They actually have like a kiosk in their building, private, of course, to protect privacy, where they can see a doctor in the little thing through telemedicine.
That's pretty cool,
I think I've seen that actually.
Can you imagine? I mean, it's very smart, obviously, but some people may not feel as comfortable. But you want to know something? For routine visits, they keep their employees, you know, at work. They keep them happy, engaged, healthy.
Yeah.
Because unhealthy employees don't help them, obviously. It's in their interest, it's in the insurance company's interest and the doctor's interest to keep you healthy. So that's where I'll leave off. Where value-based reimbursement is going to rethink the way doctors make money based on being able to show that the quality of their care is actually improving the patient's life.
We really appreciate you breaking down for us, and there surely will be a part 2. Michael Fishweicher from EMR Consultants, and we thank you for watching, and you know, hopefully we're going to be pushing out more content, you know, soon enough, and you know, we'll see you on the next one. Thanks. Peace.
Can't forget the peace.